Thank you so much. I wanted to welcome everyone and again to thank Elizabeth and Mark and for being here. It's really wonderful to see them and all of you to come out so that we can sort of celebrate you all as nurses and APPs, but also to sort of carry on what Adam wanted, which was to ensure that we had an opportunity for us to learn how we work together, especially for our brain tumor patients. So in addition to the annual Adam Clar lecture, which is what this is, and the support from all of the friends of Linda and Marks and Elizabeth, they've really allowed us to be able to have this type of an event with you. But in addition to that, it also provides the opportunity for our staff to attend scientific or educational meetings. So it's part of the educational mission, I think. And in 2024, I was very pleased that we could support 5 of our team members to attend the SNO annual meeting. And I think the importance of this is just the value of professional growth, the opportunity to network, and to gain new knowledge that can be then incorporated into our practice. Because the world is changing, the science is advancing, and it's really important that we keep up, not only from the physician's point of view and the science piece of it, but really from how are we taking care of our patients and what are best practices that might be happening internationally that we could bring into our clinic. And I think that was the vision that was really formed with this fund. So I just wanted to put a few quotes from 5 of the attendees from last year. And you can see how this is really achieving what we hope for. So, experience was incredibly enriching, greatly contributed to my professional growth. It allowed me to make meaningful connection with other nursing professionals, able to focus in areas of patient supportive care, new symptom management developments. My practice will be more patient-centered, comprehensive, informed by the latest evidence, ultimately leading to improved outcomes for my patients. I love this one. Work is where we spend so much of our waking hours. So being able to continue fostering our relationships outside the office in this setting was quite impactful. And lastly, which I think every one of them said, and I wanted to echo, we are truly grateful for the opportunity to learn, to grow, and help shape the future of neuro-oncology nursing. So again, I want to thank you so much so you know how impactful this has been for our team and for our nurses. So thank you again very much. So I will hand it over to Cherrie. You met her already, but she didn't really introduce herself. She is the nurse manager for the Gordon Murray Caregiver Program. As you know, this is a program that was started because our families of our patients told us how important it was to take care of them as well as the patients. I think we do a fantastic job now of both, which is wonderful, the comprehensive care that we have, which again, I am so proud that we are the only program in the entire world that has a dedicated caregiver program for our patients. Yeah. So, I'm really pleased that Margaretta is here. As you know, she co-founded that effort with me, and without her vision and her commitment and her hard work to build a program, I don't think we would be here. And she has graciously extended this to Cherrie, who has learned a lot from her. But Cherrie's doing fantastic in forging her own vision of the program, which has been really exciting. So I'll hand it over back to Cherrie, and please have a wonderful evening.
All right, thank you so much, Dr. Chang. And yeah, I was going to introduce myself right now, but hello everyone. I'm Cherrie. I'm the nurse coordinator for the Gordon Murray Caregiver Program and your hostess for this evening. So tonight is really quite special. This is our 5th year delivering this lecture series. And so really many thanks to you all for joining us year after year. There are many of you here who join us every year. So many thanks for joining us again. To our new attendees, welcome, and I hope that we see you again next year. And a really special thank you to Adam, who really came up with this idea, and this was his wish. And we honor him with this lecture, and we also thank his family who are here with us today. Elizabeth, his wife, we have Linda and Mark, his parents, and so we're really grateful to be able to do this for you all. So on your programs, on the back of it is Adam's story, and some of you may have read it already or maybe heard it in past lectures. Adam Clar, the namesake of this lecture, is a nurse who was diagnosed with a brain tumor in 2004. At that time, he was working for the Oakland A's in sales. He had a bachelor's degree in economics and a master's degree in sports management. However, shortly after his brain tumor diagnosis, and inspired really by the excellent care that he received here from all of you, he pursued a career change to become a nurse. And so 10 years after his diagnosis, Adam successfully graduated with cum laude honors from Samuel Merritt University School of Nursing in 2014. Shortly after graduating, he worked part-time as a school nurse and later as a cardiac nurse. All this really goes without saying, and I think many of the nurses here understand that Adam juggled surgeries, treatments, such as radiation, which we'll hear about tonight, and chemo, while also managing the workload of a student as a student nurse, and then later as a new grad RN. And I know many of you are amazed because I'm amazed. Adam always led with positivity and loved to help others. He was exceptional in the pursuit of his goal to practice nursing, which he realized in 2016 as an RN on the cardiac floor in Fresno. Sadly, in 2018, as he was about to start a dream nursing job at Dominican Hospital in Santa Cruz, he underwent a 5th surgery for recurrent disease. 6 months after that, Adam passed peacefully at his beautiful home in Santa Cruz at the age of 39. So as both a nurse and a patient, Adam understood the importance of continuing education for nurses and all healthcare professionals. The Adam Clar RN Neuro-Oncology Nursing Lecture Fund, which Dr. Chang spoke about, was his idea and wish. And since our inaugural lecture in 2019, the fund has allowed us to continue this dinner and lecture year after year. And it's become an opportunity for nurses and healthcare professionals to learn about the care of the neuro-oncology patient and to celebrate the amazing work that each of us here in this room do for our patients. Whether that's at the med center, the clinics, the outpatient center, in clinical research. Shout out to my clinical research team. Thank you for being here. And so we thank you for your continued support of the Adam Clar Nursing Lecture Fund and for joining us for this lecture. So I would like to take this moment. We also honor one of our nurses. We present the Adam Clar Neuro-Oncology Nursing Award. And this award is presented to a nurse who exemplifies outstanding leadership, dedication, and service to the neuro-oncology population and the neuro-oncology field. Our first awardee, Sharon Lamb, who was a nurse pioneer in the neuroscience field and also actually one of Adam's nurses, has graciously donated her bronze ribbon sculpture award, which she received for her outstanding work in neurosurgical nursing. And so since 2022, each awardee passes the sculpture along to the next awardee and they get to keep it for the whole year. And so this year, we are honoring a nurse leader who has dedicated her nursing career to the care of the neurosurgical patient. She graduated with a BA in psychology from UC Santa Cruz in 2007, and later with her nursing degree from NYU in 2011. This nurse leader started her career as a nurse extern, so a nurse trainee at NYU Medical Center in 2010, and moved up to become a senior nurse on the neuro ICU floor at the same hospital. In 2013, she moved back to California and worked on the neuro unit at Stanford Hospital. She then luckily transferred to UCSF in 2015, joining the Neuro Transitional Care Unit as a staff nurse, where she met several of our current Neuro-Onc nurses. So in 2018, she joined the Neuro-Oncology clinic as a staff nurse and as a clinical research nurse. And in 2023, she was promoted to nurse manager of the Neuro-Oncology clinic. She currently supervises the wonderful Neuro-Onc nursing team, our nurse practitioners and medical assistants. And really the whole breadth of her experience and commitment to neuroscience is a small glimpse into the amazing human that she is. And I know this personally. She has done an outstanding job managing our busy and growing clinic and attending to the needs of patients, families, and her staff. She is always present and available to assist where she is needed and wanted. And we are so incredibly, really lucky to work with her. So please help me congratulate and welcome our 2025 Adam Clar Nursing Awardee, Martina Kroll.
No, I'm surprised and sincerely honored, and there's no other place I'd rather be. So, and it's because of all of you and your dedication and commitment to excellence that keeps us all going, especially myself. So, I really appreciate it. It is very heavy. Thank you. All right, thank you.
Congratulations, Martina. You deserve it. You're amazing. I hope you know that. All right, so here is our program for tonight. We have two outstanding speakers, and then we'll have time for questions, and then we'll close it out for closing remarks. So our first speaker is Dr. Steve Braunstein, and Dr. Steve Braunstein is a radiation oncologist with a clinical interest in the treatment of central nervous system, pediatric, soft tissue malignancies, and metastatic disease. He has expertise in modern radiation therapy techniques, including stereotactic and intraoperative radiotherapy. Dr. Braunstein earned his medical degree at New York University School of Medicine, where he also obtained a PhD studying molecular pathways, by which cancer cells mediate response to radiation therapy. He is a member of the UCSF Brain Tumor Center, Pediatric Malignancies Program, and the Sarcoma Program. At the national level, he serves on NRG and COG core committees, and he's also involved in clinical trial design and implementation for a number of adult and pediatric malignancies. His research focus is integration of modern multidisciplinary therapies to improve outcomes while minimizing acute and long-term toxicity. He is also committed to the education of the next generation of radiation oncology leaders, serving as residency training program director. Please help me welcome Dr. Steve Braunstein.
Thank you, Cherrie. Thank you, everybody. It's a real honor to be here today, and for me, being able to spend time with all of you, the nursing staff, nurse practitioners, assistants, all together, working for the best care for our brain tumor patients is just outstandingly rewarding and a big part of, I think, why we're all here and why we continue the fight against brain tumors. So I'm delighted to participate in this evening's activities and have a chance to learn from all of you as part of our agenda today. And also I need to update my picture as the years have come and gone. Okay. So I'll be speaking about personalizing radiation therapy for patients with primary brain tumors. And this is really just the very basics. I'll talk about how radiation therapy is an integral part of brain tumor care. I'll be very transparent about while it's very effective, it can have a number of side effects that we need to manage as a team. I'll show you how some of those side effects are being mitigated as the technology improves over time. And I'll focus on this theme of less is more as we think about personalization to deliver effective therapy to areas that we need to, but also reduce treatment of areas that perhaps don't need to be treated, simply put. So radiotherapy is well established as a modality of treatment as part of interdisciplinary care for brain tumors. And this is just a snapshot of I would say, the more common tumors where radiotherapy has some indication. So it includes meningiomas, schwannomas, pituitary tumors, medulloblastomas, and gliomas. And we'll talk a little bit more about specific advances in some of these areas in the next 20 or so minutes. As a radiation oncologist, first and foremost, I will say that it's really surgery that's a primary treatment for patients with brain tumors. And many of you are very closely involved with the surgical teams. Shown here is my colleague, Dr. Herbie Jumper, performing mapping and tumor resection, likely with his colleague, Dr. Mitchell Berger. Surgery is effective in both having a role diagnostically to understand the nature of these tumors. We think about now with modern therapies, the best approach for treatment, but it's also therapeutic. It can immediately relieve what we call mass effect or pressure in the brain. And with these more modern surgical techniques, many of which have been innovated right here at UCSF, we're able to do surgeries even more effective than before. So shown there on the right is track mapping to avoid critical pathways during resection to be able to resect the maximal amounts of tumor without causing significant injuries to patients. And there's other things that can be done, such as 5-ALA to help identify tumors to assist with resection. So there have been a number of advances, certainly surgically, to make these resections even more effective. But it's important to recognize that the brain is a very sensitive and certainly components of it eloquent, we say eloquent components where surgery is just not possible. Some parts of the brain are more amenable to surgical resection, even with these advanced techniques than others. So I show on the right the deep-seated structures of the brain, the pons and the brainstem. This would be considered for most a no-fly zone in terms of resection. But as compared to surgery, radiation is a treatment that can access any compartment in the brain. So it can be very powerful, coupled with surgery, in some cases in lieu of surgery, to treat these deep-seated tumors as shown here in the pons and the brainstem. If we approach it very thoughtfully in a way that we deliver a dose that's going to be effective to treat and reduce the tumor burden in that area, but not so high that we're going to hurt that area, we can continue to be very effective in what we do and couple with our partners to give the best possible outcomes. Just by way of a historical perspective, we've been using radiation for a very long time. Radiation has been used for other tumor types, since the beginning of or mid-19th century. Now here, even in the mid-20th century, we've been using radiation. And I would say that this is some of the initial forays into radiotherapy where we would treat with big fields. That's what I show here. This is in the pre-imaging era. We don't have CT scans. We didn't have beautiful MRIs. We would just take measurements and use lower, I'd say, quality, lower energy radiation techniques, but we could still access the entire brain. So shown here on the right is a snapshot of what a radiation field would look like. If we're treating the brain, we treat the entire brain. We have a beam coming from the left side, beam coming from the right side. We'd be able to use a little bit of shielding to block out the eyes and structures of the face, but it's a very comprehensive therapy. And while effective at treating various tumors, it's also recognized that these big types of field of radiation can cause a fair amount of toxicity. And I enumerated some of them here, but you can see gliosis, these white matter changes, you can have vascular injury, strokes. It can affect cognition, lead to a diminished quality of life. In the current era, as we're giving various forms of chemotherapy, targeted therapies, there can be augmented toxicity when given at the same time. And ultimately, in many instances, it represents an over-treatment when we're using these comprehensive fields. So we recognize that, and we have attempted to curtail that over time. Just to understand how we approach this radiation treatment is very much an empirical science. Sometimes I reduce it to saying it's like a Goldilocks approach. There's a certain dose of radiation that we use. Many of the early studies, these were studies in which UCSF participated way back in the 70s, where we were treating primary malignant gliomas, and we used a particular dose, and then we had studies where we used a slightly higher dose, and we found that we had better outcomes, and a slightly higher dose, better outcomes. And then we continued to increase the dose. We added some forms of systemic therapy, and it turns out we reached a threshold where it was too much, where we were causing more harm than good. And then we back off. And these types of dose finding studies, which have been conducted over many decades, have led us to where we are now, sort of thinking about the risks and the benefits and what I would refer to as the therapeutic window, which is essentially finding the place where we're getting the most benefit and minimizing risk. I do feel compelled, this is a sophisticated audience, but just to give a little bit of 101 in terms of what radiation is. Because even though we're caring for these patients, and again, I think this group is well versed with some of the nuances of radiation, I think it's just important to point out that what we're actually doing with medical radiation is we're using ionizing radiation as a part of the electromagnetic spectrum to deliver this treatment into patients, into tumors, into tissues, and that it breaks bonds. And this radiation is very similar in quality to radiation that you might find in the upper atmosphere. Astronauts on the space station spending a long time there are actually getting some significant doses of ionizing radiation. But this is what we're actually harnessing. And I make the point that what we're actually doing is we're causing DNA damage. So the radiation that's focused into tissue, it's causing cleavage of water molecules, become free radicals, and then they interact with the DNA within the nuclei of tumor cells and disrupt it. They disrupt it in a way as these tumor cells are dividing aggressively over time. They're not able to maintain what we would call that genomic fidelity, that critical blueprint which allows those cells to remain viable. So they accrue all these damages, mutations within the DNA, and those cells die. That is how it works. At very high doses, it can have impacts on proteins and fats, but what it doesn't do, it's not a thermal effect. So it's not like a laser, it's not like a laser interstitial thermal therapy. There's no caloric component to it. If you actually took like a glass of water, which we kind of do for calculation purposes, and I'll describe that later, and put it on a radiation machine and gave a treatment of radiation, it wouldn't raise the glass of water by a degree. It doesn't have that kind of thermal energy. It's true that one of the side effects is that patients can get skin irritation. Certain types of treatments we do, especially more superficial treatments of the brain, there can be what would be referred to as burns on patients, but it's not due to a thermal effect. I'll describe what that is in a moment. The other thing is, why does this work? Well, it works when tumors are more sensitive to a particular dose than normal tissues. And actually, for the most part in the body, those tumors that are more actively dividing tend to be more sensitive, whereas cells that are, or tissues that are not dividing are less sensitive. So within the body, the brain is actually pretty robust. There is some neurogenesis, there is some turnover, but for the most part, it's a pretty hardy tissue. And tumors that are within the brain or near the brain are more actively dividing. They actually are more sensitive. So for the most part, we have this favorable relationship where it takes less dose to kill tumors than it does to hurt normal tissue. But despite that, there still can be some impact on normal tissue. Even if it's a small fraction of normal tissue, that can carry with it significant side effects, both acutely and late. And so much of what we have done in radiation over time is to give small doses every day over a period of several weeks. We do this even though it's logistically encumbering because it's a safe way to deliver radiation. What it allows to happen is that every day we're always treating tumors, and we're treating tissue that's either admixed or around that tumor, so it's dose that goes to these normal tissues. By doing this every day and having a period of rest in between each session, it allows some of these normal tissues to repair that damage. Whereas tumor cells, because they're already disrupted genetically, they tend not to invest the resources to repair that damage. So they continue to accrue damage, mutations. Normal tissues are able to recover that. So what we do is we give a little bit of dose every day, and that widens that therapeutic window. Still can hurt normal tissue, but it will hurt it less than if we give a big dose of radiation in a single session. That's what this shows, at least historically. This is the modern linear accelerator. They're compact, they run on electricity, they plug into a wall, big step-up transformer, just like a washing machine, maybe a little bit more than that, but essentially what it's generating is electrons, high energy electrons that are then collimated and then enter into tissue. Most of what's in that machine are various measurement devices to make sure that we're delivering the radiation at the dose that we want. Also, what I would call collimators, or devices that help shape the radiation so it can be as focused and homogeneous as possible. That's most of what's in these machines. But there's other specialized technologies we use, and I'll get into it a little bit. Gamma knife, cyber knife, tomotherapy, they all have special purposes and really try to deliver radiation as focused, as specifically as possible. So just talk a little bit about pathway. Many of you with whom I work know this pathway well, but I'm going to focus on maybe some parts that you might be less familiar with. So first and foremost, again, this is really just 101, is the W's when we see a patient in consult. Who, where, why, what, and when. So we're thinking about when we see a patient, we're often doing this in an interdisciplinary fashion. Who is the patient? What's the disease? What's the prior treatment? What's special about their particular situation? We're thinking about psychosocial factors. We're thinking about logistical factors. We're thinking about goals of care. We want to give, at the upfront, understand the patient and give the best possible treatment for that patient with the tools that we have. Sometimes there's the why, and sometimes this can be the most challenging component. What's the evidence that radiation is effective? Yes, we can deliver it. We have fancy machines that can do this, but is there actually going to be a benefit in a particular case from delivering radiation therapy? And many of our patients are very complicated, have very complicated histories. And just like with surgery, we really have to be thoughtful and adjudicate who is the right patient for a particular treatment. What's the target? Sometimes it seems obvious what we are treating, the little thing that lights up on a scan, but sometimes it's much more complicated. And I'll show you that with some of the examples here. I showed you a little bit of the machines. What modality is most useful in particular situations? We have machines that can treat big areas, small areas. We have machines that can treat things that are moving, not so important in the brain and spine, but could be important in other situations. And then the sequencing. Again, we don't work in a vacuum. We work with all of you. Patients are getting surgery. They're getting systemic therapy. Where does radiation fall within that pathway to get the best effect? So some of you are aware with this. When we have a patient after we deem them appropriate for radiation, they undergo a simulation. We also call it a mapping session. All this is preparing the patient for treatment. Usually it involves a CT scan of the area that we want to treat, sometimes an MRI as well, and an immobilization device, which seems rudimentary and is somewhat rudimentary, but we use these thermoplastic masks that appear sort of flat plastic masks. We warm them up a little bit, they become very pliable. As they're very pliable, we apply them to the contours of the face. And the purpose of this, again, very rudimentary, is just to keep the patient as still as possible for the few minutes that they're receiving treatment so that we can be as focused as possible with the radiation field. It looks very striking. It can be very striking. It's part of the patient experience to go through this. Certainly, if you're prone to claustrophobia, there are things we can do to make it a little bit more comfortable. It shouldn't be painful when you're wearing this, but it is a part of the treatment pathway that I think for some can be a little bit off-putting, but it does allow us to be as focused as possible when we're treating. So we do run the simulation where we collect this information. Then what happens, and this part maybe you all don't see as frequently, there's a team. There's a team with whom I work, an excellent team of physicists, dosimetrists, assistants, others who help generate the radiation plan. It starts with me as the radiation oncologist, using all the available information, clinical imaging, to be able to delineate areas. So for example, in a patient with this glioma, to be able to delineate the areas that we need to treat, and then also delineate areas that we don't want to treat because they're sensitive, or we recognize that putting radiation to those areas, which is not required because they're not areas of tumor spread per se, can mitigate some side effects. One of the things you might appreciate here is just the nature of these treatments. Even treating this cavity that you can see lighting up as white on the T2 flare or T2 signal, there's expansions, there's margins around that. When treating glioma, the nature of the tumor is infiltrative. After the surgeon may resect that tumor, we're really focused on treating not just the immediate surgical cavity, but that area around that cavity where there may be infiltrative tumor. That's where radiation can really partner well with surgery. But what that means is that even when you look at a postoperative MRI and you see the surgical cavity and it looks small to modest, the actual radiation field, independent of what modality you use, can be quite large. And that can be significant in terms of how that translates to the acute and late side effects for a patient. So there's a lot that goes into this, and understanding relationships between what's the right dose for a different part of the tumor, a different structure. There's different ways to look at this, but we produce these radiation plans and we optimize them in a way to give what we deem to be the best treatment possible, to give the appropriate dose to the target that needs to be treated, but minimize dose to areas that don't need to be treated. And the plans look like this to us. The other thing that I'm pretty sure none of you in this room, unless you're radiation oncologists, have seen is the very robust quality assurance process, which doesn't look all that exciting here, but can be exciting because what we need to ensure is that when we generate that computer-based radiation plan, before we deliver an actual person, we need to ensure that it is going to be delivered as we envisioned from the computer program. So the way that we do that is we have these devices, some of which I didn't show here. They're actual mannequins. They look like they'd be in a department store. But they have little dosimeters in them. And in the after hours of the clinic, we actually take those mannequins, we put them in the radiation machine, and we deliver the plan on these mannequins. We call them phantoms. And that gives us these parameters or these plots that tell us, or gives us reassurance that we are going to be able to treat in the way that the radiation plan was designed with the parameters that we wanted. And then we feel very confident about that treatment. Then there's the actual treatment. The patient comes in the room, apply this mask, they're on that linear accelerator, and we deliver that treatment. There's imaging that's done to ensure that we're localizing as best as possible. Even with this mask on, there can be some small millimeter deviations, and that's what this looks like. And then the follow-up is we're sitting around. There's former colleague, Dr. Mike McDermott, sitting around in tumor boards and reviewing prior imaging, current imaging, and ensuring in an interdisciplinary fashion that what we treated seems like it's controlled, effective, and then thinking about next steps in the planning process. So there's a number of challenges with central nervous system radiotherapy. The side effects can be significant. And I think of them, you might hear more from Krista about this, but being acute, meaning during the treatment, being somewhat subacute, sort of after the treatment, and then late, which can be months or years following. The acute are mostly temporary. The subacute are mostly temporary, and the late can be permanent. So you can see a long list of things here that can be quite significant in terms of a patient experience. And especially those late effects, the cognitive impairment, the hormone deficits, vision impairment, brain injury, vascular injury, stroke, and even secondary cancers from the treatment. So it's a lot, and even if you don't experience these side effects, just knowing that they exist, even with a low probability in some instances, can definitely be harrowing for survivors and for patients going through this pathway. The other thing that I'll point out is in addition to these more direct medical effects, are secondary effects. Going through this can present psychosocial challenges. There can be physical atrophy, logistical constraints, decreased independence, isolation, and there can be a pretty profound impact on those others who are caregiving for the patient. So we think about all these things and try to support patients as best we can as they go through this. So I'm going to talk a little bit about some specific, advances or tumor types. And I'll start with pituitary adenoma, not because it's particularly exciting for the group, but just because it gives me an opportunity to talk about a form of radiation that I think has really revolutionized the way that we're able to help patients. And these pituitary adenomas, they're benign tumors of the pituitary. They're important. The pituitary is important in hormone regulation, so some of them can have secretory components. They can have a significant impact on function. And they're usually treated with surgery or radiation, and the surgery can be very challenging to do. The surgery is often done endonasally, endoscopically, but these tumors are situated at the skull base, and it's a very difficult area to access. It's a very difficult area because there's a number of nerves and vessels that course through that area. So it's hard to resect this in completion. So radiation can partner with surgery to treat. Now I talked about traditional radiation, big field radiation. Well, that changed. Even in the 50s, the 50s is when this form of radiation called stereotactic radiation was invented. It was invented by a neurosurgeon, not a radiation oncologist, a neurosurgeon who recognized that the actual treatment for these surgical interventions can carry a lot of morbidity, and looked to find an alternative intervention that could be just as effective, but with less morbidity. This is Lars Luxel, a Swedish neurosurgeon, so invented the gamma knife. It looks very Star Wars-y, the initial iteration of this back in the 50s, but it advanced over time. This is the modern gamma knife. You can see essentially what it's doing is it's providing radiation that's very, very focused to a single point in space, a number of different beamlets that converge at a single point and allow us to give very, very focal treatments to parts of the brain. We use this to treat a number of different lesions, not limited to just brain tumors, but I show some of them up here. So I'm just going to get a drink of water. Among these lesions, you can see that many of them are very small, including the pituitary adenoma shown at the bottom there. And this particular treatment, the treatment is right up against critical structures. It's up against normal pituitary, it's up against optic nerves, it's up against vessels, but you can deliver very, very precise radiation on the order of millimeters with this particular technique. So I show a plan here. You can see axial cuts through the skull base. You can see the optic chiasm sitting right over the target there. And you're able to deliver this radiation without giving any substantial toxic dose to the optic pathway. So you can preserve vision and yet ablate this pituitary residual adenoma that's sitting in that cavernous sinus that was subtotally resected. So gamma knife has been used for a number of treatments. We use it very frequently to treat small targets, often in the recurrent setting, including recurrent gliomas, meningiomas. We'll talk a little bit about some advances in meningiomas. So we recognize these largely to be dural-based tumors that can, most of which they're very common. They can be benign or they can be very highly malignant. They can occur throughout the skull base as well as the convexities covering the brain. Even though many considered benign, just by virtue of their growth over time, they can push and cause mass effect on normal healthy structures, which can carry with it a fair amount of morbidity and even mortality. They also can be pesky in that they have a propensity to recur over time, over a lifetime. And they're generally treated with surgery or radiation. To date, there's no great systemic therapeutics, but that's something that we're working on and hopefully will change. And so I want to call out some of the great work by my colleague, Dr. David Raleigh, and at the time his fellow, William Chang. For patients who have resection of meningioma, there's often a question. I'm not going to point out any of the curves. It just looks like a lot of curves here from some good science. But there's questions about if you resect a meningioma, do you need to have additional radiation? When you resect a high-grade glioma, you need radiation therapy because of the nature of the infiltrative malignant component of it. But for meningiomas, that may not be the case. Many are benign, some are sort of in the middle, some are pretty aggressive and actually definitely need radiation therapy. But what we can do now is use molecular markers from the resected tumor to help us understand which are the tumors that are treated and cured with surgery alone, and which may require radiation in addition. And the nice thing about that is we can feel more confident as practitioners about offering radiation to patients, which again may carry side effects, but feel confident that we're doing it for a good benefit to be able to help cure these tumors and keep them from coming back. So I think the use of molecular interrogation, really the advancements in the pathology, also important colleagues, have led us to be able to be more personalized with our approach to treatment of this tumor. Another advance in meningioma and other brain tumors is the use of something we call brachytherapy. It's a very radiation-specific modality. What it is as compared to most of the radiation that we do, which is external beam, so beams coming in at different angles to a patient, this is radiation that's, in this case, placed in a little source, in a little seed that's implanted directly into the tumor or the area in the surgical bed where the tumor was situated. So the radiation is delivered from inside out. It's a source radiation, just like other sources you may be familiar with, uranium, plutonium. We're not using that, but we're using these radiation sources like cesium-131, which has a relatively short half-life, which means that it gives up its radiation and then it's inert. So we can, and you can see these seeds are very small. So we can partner with our surgeons, often for patients who've had, say, a meningioma. It was resected. We gave radiation, but this happens to be an aggressive one and it comes back. What can we do? Well, we can put the patient through another surgery. We can put them through more radiation, external beam, but that takes a toll and that can be associated with a fair amount of toxicity, especially in the retreatment setting. Using this type of technique by delivering the radiation immediately in the area where the area at risk is present, we can minimize, give high dose to that area, but minimize dose to the surrounding healthy brain tissue. So it's a way to be even more focal and conformal with the radiation. So we do a fair amount of this with our colleagues in surgery. It's also being used in other settings such as glioma, but I think it has in the primary brain tumor setting, the best data really is in meningioma. And so shown here, you can see this lesion present in the posterior fossa, had prior radiation, recurred, was resected with these little seeds that are present there. They show up on CT scans and MRIs. And from our experience, when you can get a complete resection and use the seeds, these patients do really well. You can see the curve at the top. Follow them over 3 years, the tumor doesn't come back. So this is something that can be very powerful for the right patient. So it has to be in a location where we can effectively resect and deliver these seeds. So it's nice to have this tool to help patient. Another advance here's a current trial we have of immunotherapy combined with stereotactic radiation. Dr. Nancy Bush is running this trial. And there's a lot to see here, but for some patients with meningioma, what we're seeing is that while historically systemic therapies haven't been effective, if we combine some of these newer targeted immunotherapies with radiation, we might be able to potentiate the effect. So this is a patient who had multiple recurrent meningioma. You can see on that skull base and the axial and coronal right at the temporal tip near the left orbit. And so I had multiple resections and then went on the clinical trial. I should say it's personalized in the sense that there was something about her genetics and the genetics of her tumor in particular that seemed to make this amenable to immunotherapy and the stereotactic radiation therapy. And she had a tremendous response months later and at least initially did very well with this treatment. So new possibilities in terms of combining therapies. So talk about medulloblastoma. I mean, this is a very peculiar brain tumor. As noted, I take care of both adults and pediatric patients with brain tumors. This is not something that we frequently see in the adult setting, but we do see it in the adult setting, more commonly in the pediatric patient setting. It's another form of what we call an embryonal brain tumor, very dedifferentiated. And it tends to occur in the posterior fossa. So patients will present, young patients, anywhere from really age 2 or 3 up to teenage years. Most commonly children around 6 or 7 with a mass that grows in the posterior fossa near the fourth ventricle, can cause obstruction of that ventricle. The patients present with hydrocephalus, ataxia, cranial nerve deficits, headaches, nausea, vomiting. And it's usually treated with surgery and then chemotherapy plus radiation. The peculiar thing, every tumor has different biology, but about this class of tumors is they have very high propensity to disseminate through what we call the craniospinal axis, the cerebrospinal fluid in the brain and the spine. So that makes it challenging to treat, at least historically. And so the radiation treatment that is still used today after a surgery is really designed to encompass the entire brain and the entire spine. Now, I'll note that seems like a very extensive treatment, and it is, and it can have a lot of side effects, but these patients can be cured. And it's important also from a survivorship perspective, making sure that they have the support and their needs addressed throughout life. But one of the things that we've been able to do to improve the way that we're delivering this radiation, again, comprehensive, is to use newer forms of therapy, such as proton therapy. So I have a synchrotron shown on the right. It's this big device. These are not like the linear accelerators that sort of fit in a room like this. These are machines that need to exist in like 3-story buildings. It's a lot more intensive to deliver, but the physical property of proton versus what we normally do, external beam photon radiation, is it can deposit dose in a way that's very narrow. Most of the radiation that we do, the reason that many patients have side effects when we're treating big fields is there's what we call scatter, or there's radiation above and beyond what we're treating in terms of the target, so it goes to other parts of the regional brain. There's a special physical property of protons where when it enters tissue, you can see that little curve there, it enters tissue, it's a form of external beam, comes in, it puts the dose in a very narrow area as a function of energy. So it doesn't have a high entrance dose. We say it doesn't have a high exit dose. When you look at the picture, the wash on the left, what you can see, if we're treating a patient with traditional photon-based techniques, there's a lot of dose that goes outside of that craniospinal axis. A lot of dose goes to the anterior viscera, the heart, lungs, liver, kidneys, essentially the entire anterior or ventral structures. What protons can do is can deliver it in such a way that it's really just treating the brain and the spinal canal. It can even stay off much of the vertebral body, so it's very powerful. It's less marrow-suppressive, less likely to cause issues with concurrent chemotherapy. And this has been demonstrated when you look at folks who are late survivors who've had proton therapy, they actually have fewer long-term toxicities. The other thing to recognize, similar to what I showed you in meningioma, is that just like other tumor types you might be familiar with, lung cancer, breast cancer, we recognize that even a single name tumor, medulloblastoma, is not really a single tumor. It's actually a class of very related tumors. And so understanding sort of the specifics of a patient's tumor helps us personalize their therapy. And what we've discovered is that not all medulloblastomas are the same. As a matter of fact, they have different molecular drivers, and that has consequences in terms of what kind of treatment they need. In some cases, what it's allowed us to do is partner with our neuro-oncologist, medical oncologist, to offer very specific targeted molecular therapies for specific subtypes that are effective to improve outcomes. But also, importantly, some of these subtypes don't require the same high dose of radiation than others. So it allows us to, what I'd say, de-intensify the radiation. So we can give less dose to very specific subtypes and have just a good outcome. We can cure these patients with lower dose. There's a number of trials that are being run in this area, but this is definitely an instance where less is more for some subtypes. So the last area that I'll talk about here is glioma, which I think is the predominant tumor patient population that we treat together. The standard of care for patients with high-grade glioma has been surgery and chemoradiation. This has been established a number of years. I showed you some of those initial radiation studies from the 70s that were dose finding. But our current paradigm, which I think the group is familiar with, is maximum safe resection, followed by 6 weeks of radiation, 30 fractions, 60 gray, our unit of dose that's given concurrently with temozolomide and then adjuvant temozolomide. And there were studies that were run that now, 20 years out, that established this as the standard of care. And from a radiation standpoint, and I intimated this earlier, what are we treating after a resection? We treat that surgical cavity, and then there's usually a margin that we treat around it that's a couple of centimeters to treat this regional infiltrative disease, because that's not always visualized surgically, and it's sort of the balance between getting that maximum or super maximum resection, but not being so aggressive to leave patients with significant deficits. From a radiation standpoint, even though this disease is infiltrative, we know that biologically it respects certain anatomic boundaries. It's not going to cross the falx, but it could cross through the white matter tracts of the corpus callosum. And again, when you look at this, you can see that even with this modest surgical cavity, the actual radiation, maybe it doesn't project so well, certainly from the back, can be significant. It can look like we're treating about a quarter of the brain. So that can carry with it a fair amount of toxicity. There are some advances, slow advances, mind you, that have been made towards personalization. This is not something that I think we're all necessarily excited about, but still it's meaningful that for patients who are older age, for patients who have lower performance status, it's been shown that you don't necessarily need to subject them through the full 6-week course. In some cases, you can do that in just 3 weeks, 2 weeks, or maybe even 1 week. And some of those patients still may benefit from concurrent or adjuvant chemotherapy. But from a patient-facing perspective, this can be meaningful. We want to offer something that's going to benefit patients and minimally encumber them, and being able to treat them more quickly with the same outcome, I think is something to be mindful of. So it's part of those W's when we're seeing a patient and thinking about what's the best treatment for them specifically. Now, at the same time, this may actually be an instance where more is more. What we have found with more advanced imaging techniques, a lot of that imaging being, again, spearheaded here at UCSF and a few other institutions, we can better identify areas of disease that may not be clear on traditional anatomic imaging. So you don't see it on MRI, standard MRI sequences, but when you do some of these multi-parametric MRI images or spectroscopy or hyperpolarized agents, you can see evidence of disease. And if you target that specifically with maybe a higher dose of radiation than that standard 60 gray, some studies have actually shown improved outcomes. Patients are living somewhat few to modest months more. So it is moving the needle potentially a little bit. Work that we're doing here is from Janine Lupo and her team. We are looking to see a little bit of more is more and less is more, which is potentially intensifying dose at these areas where the imaging suggests that there's residual active tumor, but at the same time moving dose away from those areas that do not seem to have presence or signal of tumor. And that can have consequences in terms of quality of life, in terms of how patients feel acutely or at long terms after treatment. So really this idea of personalizing radiation therapy, or even doing it over the course of these 6 weeks by getting interval imaging and sort of adapting or modifying what we're treating, because these tumors do evolve even over the course of 6 weeks of treatment, can be impactful for these patients. And much of this work is being done in the high-grade glioma space, but it may be even more impactful for those patients with lower-grade glioma that presumably will have longer survival and actually, unfortunately, manifest many of these side effects of radiation. So if we can mitigate those, that would be really impactful for this patient population. And the other thing, and this is as less as it gets, is that in some cases we might be able to avoid radiation altogether. So this is data from the Indigo trial. Many of you are familiar with this here. but maybe too familiar. This really champions, I think, the revolution we see in the molecular understanding of tumors, understanding the alterations and mutations that are driving some of these tumors, such as IDH mutation, and then the development of targeted agents that can very specifically impact the growth potential, the malignant potential of these tumors, and treat these tumors effectively. We're not at a place where there's a magic pill, but we're at a place where the pipeline of development of these agents, I think, is really encouraging. And so this was a trial that was run in patients with recurrent IDH mutant gliomas, lower grade, and that found the addition of this agent was able to produce a meaningful progression-free survival benefit. These were patients that were not irradiated. So this has already changed practice. Many of these patients otherwise at the time of progression would be considered for radiation therapy, and this may be a mechanism to defer or even obviate radiation ultimately for patients. And anyway, at least reserve radiation for when they do progress later on, maybe through these agents, and it would be more powerful and more meaningful at that time, thinking about the risks and the benefits. So in summary, I'm just going to reiterate that radiation is a very important role in our interdisciplinary management. You've seen some of those advances in technologies, the use of biomarkers, and just the now very rigorous clinical research studies are improving our precision-based care. But ultimately, it comes down to the patient that's in front of you in consult, thinking about, what is the indication for radiation? What's the benefits? What's the potential risk, the side effects? What's their specific goals? And how can we work as a team, all of us, to support them through this journey? So with that, I thank you, and I'm happy to take any questions you have.
Thank you so much, Dr. Braunstein. All right, so I'll introduce our second speaker, and then we'll do questions after. I'll invite both of them up again, and we'll do questions. So our next speaker is one of our Neuro-Oncology nurse practitioners, Krista Ruff. Krista is a nurse practitioner with a decade of experience in adult patient care. Her professional background includes a focus on solid tumor oncology and specialized training in adult neuro-oncology. Krista currently manages the care of patients undergoing treatment for primary brain tumors. She earned her nursing degree from the University of Colorado and subsequently obtained her master's degree here at UCSF. Krista's professional interests include the management of chemotherapy side effects and the provision of care to individuals living with cancer in rural communities. So please help me welcome Krista.
Thank you, Cherrie, for introducing me. And a special thank you to the Clar family for continuing your ongoing support and Adam's vision to have the growth of our community that allows all of us to be here together tonight. So I will be talking about intracranial radiation, and specifically with a focus on the patient journey through the nursing lens. As nurses, we can't ever really know what the patient journey is, but we see them step by step and can kind of get a perspective of what it's like to go through this. So we're taking it from that approach today. Just briefly, our objectives are listed here. So Dr. Braunstein did a great job of covering objective number 1. So I will really go on to talk about some of the side effects or toxicity of brain radiation at both initial treatment, maybe at tumor progression. And then I'll talk about some of the common challenges that patients from our rural and our low-income patients face during radiation treatment, and at least a couple of things that we can do as nurses and support staff that really help patients get the treatment that they need. So I know we're not physicians, but I love this quote. So the good physician treats the disease. The great physician treats the patient who has the disease. I think this is a really good lens to look at our talk today of, yes, we're treating the disease. We're using the science to treat the disease, But in order to do that, we really have to know the patient who has the disease, and we have to meet them where they are. So just briefly to review the diagnosis of CNS tumors. So through my research for this talk, I found out that the first histological differentiation of brain tumors was exactly 100 years ago, so in 1925, and has really significantly evolved over the last 10 years with the inclusion of molecular markers in the diagnosis. And today, the picture on the right, we have the ability to analyze a tumor's genome and find unique methylation patterns that really help diagnose tumors, which histologically may have been hard to diagnose before, which really helps to guide their treatment in a way that maybe we didn't even have a path moving forward before. I also like to say that in 2021, as of 2021, the WHO classifications, there's more than 100 primary CNS tumors. So really this very small list is the things that we see most commonly, but I really wanted to focus in on what we see in adult primary brain tumors and really what we see a lot of in clinic. So another recap of our multidisciplinary care that we give here. So all aspects of our patient care are best approached through an interdisciplinary lens. And the treatment of primary brain tumors, I would say, is no exception to that rule and is rather a very critical aspect of the care that we deliver and that we're able to deliver here at UCSF. All three disciplines, in working all together, we all use this therapeutic index. And Dr. Braunstein talked a little bit about that, what that means in radiation, controlling the tumor growth the best that we can while minimizing the side effects. But that's also true from the surgery standpoint, taking out as much tumor as we can without affecting a patient's quality of life in terms of their mobility. And then again, on the medical oncology side, where we're thinking about the toxicities of chemotherapy and how we can best mitigate those, and so that it keeps a patient's quality of life high throughout the course of their treatment. The patient journey, I really would just like to highlight that every patient's journey is going to be completely different. It's important for us as a healthcare team to remember that the road is not linear. And at any point, this road can become a circle, right? So we can meet a person after surgery, we can go through all of their radiation planning, we can get to follow-up and imaging. They have a recurrence and they're back at surgery or they're back at radiation. So this road is never ending. It's also important for us to know that whatever path or wherever they present in their path to us, whether it be they had surgery elsewhere, they had radiation elsewhere, they present to us in the medical oncology sector, we're still using that interdisciplinary approach. We're not just approaching it, they've already done this and we only need to focus on their medical management now, but we really take a look at those patients in our tumor board with a whole lens of is there anything else from the other modalities that we can do for these patients? So Dr. Braunstein had 5 W's. I will talk about 4. I left out the why because I knew that he would cover it. My 4 W's are just a little bit different, but he also touched on them. So when we think about the who, we're really thinking about who is that person? What is their age? What is their functional status? Who is their support system? Who are they in charge of supporting? When we think about the what type of radiation are they getting? Are they getting fractionated, hypofractionated? Are they getting SRS? What is the treatment field? How big is it? What other things can we maybe expect from their side effects before they even start treatment? When are they getting it? Is it post-biopsy? Is it post-surgery? Is it at the time of the recurrence? Have they had this type of treatment before? And where, and not necessarily where in the brain, but as much as we would like to house all of our patients at UCSF, we just can't. And we have to take into account what is the cost to the patient? Can they make it here for treatment every day for 6 weeks? If they live far away, can they get treatment that is reliable, close to home? And who do we know in our network of physician colleagues that can maybe deliver that? So treatment planning and initiation and completion, this is kind of the start of our acute toxicities group. So just to recap that this phase can take 2 to 8 weeks depending on the radiation type and the dose, and starts approximately 4 weeks after surgery. So we really have to think that by the time that patients have surgery, the rest of this is a big kind of sprint. They're getting so much information. We talk about all these toxicities. We talk about chemotherapy toxicities, and it can be very overwhelming for patients and their families. So really taking a step back while we're doing this planning and initiation to prepare them for as best we can for the road to come. So like Dr. Braunstein talked about, normal tissue injury depends on many factors, including the total radiation dose, the fraction size, so like how much is being delivered at a single treatment. Someone spoke to me about this in terms of pie once, and I really like that. Like if you're giving a whole dose of radiation as a whole pie, your fraction dose is 1 slice. So what is that compared to what is a patient receiving for 1 slice? And then are they getting concurrent systemic treatment at the same time? Have they had past treatments? And what is the anatomic location of the tumor? So these toxicities, like Dr. Braunstein talked about, are the acute toxicities. So we're really thinking about the time of radiation from the time it starts to the time it finishes or shortly thereafter. Fatigue is the most common by far for our patients. And that's even more so in our patients that are also receiving systemic therapy. So in up to 90% of patients, the timing is really week 1 through the end. And it really builds over the course of radiation from patient report. And so preemptively giving them that education that you will feel fatigued. This will kind of come to the end of radiation, and it can extend for weeks or months after radiation concludes as well. The best combat to that, and I always tell my patients, is not taking extra naps, but is moving your body, doing exercise, staying as mobile as you can. There have been some medications, so modafinil and methylphenidate, that have been studied, but neither of them have shown great outcomes in improving fatigue in the short term or in the long term during treatment. The second most common is hair loss. And that's really kind of at the location where the radiation dose is entering the tissue and occurs anywhere to 70 to 100% of people, depending on their radiation dose and how many fractions they receive. This is not something that starts initially. It doesn't start on day 1. So it's important to counsel our patients that it will happen. And then, so timing is 2 to 3 weeks after initiation. Treatment is trying to prevent where you can. So gentle hair treatment, making sure they're not putting a ton of chemicals on their hair. Are they washing it gently, brushing it gently, kind of avoiding heat where they can. Treatment is time. Eventually, most people's hair will grow back, but it's also important to counsel them that their hair may be different. They may have a different texture. It could be a different color. And so for a lot of people, this portion of things can be very anxiety provoking, mainly because a lot of our patient population, they may not project what I've heard is the typical, I don't look like a cancer patient. And this is one portion that maybe makes them feel like they are a cancer patient. And so counseling them on how we can try to prevent that. There have been some studies about topical modafinil. All of them have been kind of retrospective studies and not at a consistent dose or looked at in a prospective way. So it's not proven therapeutic yet. And then thirdly, an acute toxicity is scalp and skin irritation, like Dr. Braunstein talked about. So as high as 90% of people can be redness, rash, pain, itching, and in severe cases, some wounds or burning of the skin. Happens typically after the hair falls out. So you have that area of alopecia, and then the skin damage can come on from that. Treatment, again, is prevention, taking care of the skin, using calendula, emollients. If there's a rash, topical low-dose steroid. It's really important that those of us who are not seeing these patients every day in radiation oncology, if we get a message, right? If we're triaging something, we get a message about this, that we reach out to our radiation oncology colleagues and say, hey, I'm thinking about doing this, because we don't want to put on something that's going to interfere with their treatment. And we want to make sure that we're respecting their guidelines that they give to. And then interestingly, kind of a red flag for us is we need to take special consideration of people who have recently started Dilantin or Tegretol. The rash around their radiation site, if it's extending beyond the field of radiation, can sometimes be the first sign of Stevens-Johnson. So just a little tidbit. So a couple more things about acute toxicities. Appetite changes and nausea can happen in about 50% of people with appetite loss or a decrease in the appetite being more frequent than the nausea. The timing can be from the day they start radiation to the day they finish radiation. And things we can do or encourage as nurses is just variation in your food. If it doesn't taste good, if you don't want to eat it, don't eat it. Like, eat something that's going to sound appetizing to you. Have smaller, more frequent meals throughout the day. A lot of this has to do with, are they doing systemic therapy at the same time that's also affecting their appetite? So giving them guidance on kind of how to manage that throughout their day. And then antiemetics like Zofran when needed. And then headache. Headache is a common thing in a lot of our patients. Symptoms can be mild, aching, they can be transient, kind of come and go headaches. We go back to our over-the-counters using some Tylenol, but also using our CAM therapies, our complementary alternative medicine therapies, ice and cool compress, ice to the head, warm to the feet. Can they do massage? Are they having tension headaches because of all the stress they're going through, because of the positioning that they're in, even though it's just a short period of time? Now, a headache that is co-occurring with new somnolence or new neurologic changes is something totally different and really needs to be examined by one of our providers. And then while I think we're all very familiar with the fact that location plays a role in the symptoms that a patient can experience, we should also use this knowledge when it comes to educating our patients and our families about the possible worsening symptoms during radiation. So radiation can create inflammation in the area of the tumor, or where the tumor was, maybe. And it's important for patients to know that, okay, maybe you do have a little bit of increased right-sided weakness. That doesn't mean tumor regrowth. That's the immediate question that I get is, I'm really worried that I have this symptom that's the same as when my tumor was there. Is it coming back? How do we know? What do we do about this? And then it's really important to educate that taking an MRI during radiation is not necessarily helpful. That in cases where it's side effects that seem mild, that maybe we could control with a little bit of steroid, that maybe they get a little bit better. Getting a picture is not necessary. But in big changes, somnolence, huge neurological changes, we should, of course, be considering, is this patient have a new cystic component of the tumor that's pressing on a part of their brain that maybe steroids isn't controlling? So taking into account that, yes, maybe an MRI isn't the go-to thing during radiation for diagnosing, is it tumor, is it swelling? But really, we should still rely on it when there's big changes in our patient population. So pseudoprogression. Now, in my preparation, there's a lot of debate between what is pseudoprogression, what is radiation necrosis, and what is the delineation between when it's pseudoprogression and when it's radiation necrosis. So we'll talk about them both a little bit. But pseudoprogression is occurring in this acute toxicity phase, so immediately following radiation. Incidence as high as 50% in some of the studies. This is really dependent on the dose of radiation. I think it's also dependent on the person who makes the radiation plan, what kind of plan they make. Can they contour the space really well? Symptoms. Patients can be symptomatic with worsening of their presenting symptoms. So frontal lobe tumors, are they having personality changes? Are they having some of that executive function change that feels different to them? Are they having new weakness? On MRI, we can see, and on the farthest right, and I'm sorry if it's small, this patient, the furthest right is a post-contrast image of pre-radiation. So this is post-surgery, post-biopsy of a multifocal glioblastoma. This patient underwent 6 weeks of standard dose radiation. And the middle there is the post-contrast scan from the 4 weeks following radiation. So you can see a lot more contrast enhancement there. And then the third picture is what we'll get to in just a second when we talk about treatment. But they're here on the bottom left. That first image is what correlates to that middle image there of the post. This is a T2 flare of the post-radiation treatment. And so really recognizing that as best as our radiation colleagues do to contour the area to get the least amount of dose to normal tissue, there's still significant edema that can happen in the brain as seen in that T2 flare. And so our treatments are really, if patients are asymptomatic, can we just give them a little bit of time? Will this get a little bit better on its own? If their symptoms are bothersome, can we start them on steroids right away? Can we get them on some dexamethasone and improve that swelling? And then lastly, in patients that maybe we can't get completely taken off the steroids or off of a taper, do we need to consider giving them Avastin or bevacizumab, which is an anti-angiogenic monoclonal antibody infusion that, as I like to tell patients, puts a Band-Aid on those leaky vessels for a short period of time, and it kind of allows it to heal. So what we're seeing here on the farthest left is the T2 flare of this patient after just 2 doses of Bev. So really had some improved radiologic findings, but also presented with complete left hemiparesis, not able to move. Her left side was already on steroids through the course of her radiation, so we knew we probably wouldn't be able to get them off without the Avastin, and had kind of complete resolution of symptoms by the time we had treated her with some Avastin. Sorry, one more thought here. MGMT methylation status is something that we really need to take into consideration when we're looking at these post-radiation MRIs, because it's shown that people with MGMT methylated tumors, they're more likely to have this presentation of pseudoprogression compared to those who are unmethylated. And when looking at overall survival, we also see that, not directly correlated, but pseudoprogression has some improved overall survival in the long run. Okay. So now we'll cross over into the time that radiation ends, and we can look at this as like the follow-up and surveillance phase. So like I said before on our roadmap, this is not the end of the road. This is just the start of the road. And so for many of these patients, they're being followed with MRIs every 2 to 3 months initially. And this is lifelong follow-up. While those MRI scans may get further apart, while we hope we don't have to jump back to the beginning of our road here, just always counseling patients that we will always see you. You will see us for the rest of your life. So one of the really big late toxicities, which Dr. Braunstein talked on too, is the cognitive changes. So this can be one of the most difficult late toxicities for patients to experience. It can occur in about 90% of our patients in some degree. And the most commonly affected domains are that executive functioning, psychomotor functioning, and memory and attention. So really things that impact everyday life. Cognitive changes can have not only a direct impact on our patients, on their quality of life, their independence, but also the amount of caregiver support. So can really change how much caregiver support that they need throughout the course of their treatment. It's also important to remember when we're talking to patients in the clinic, we're asking them, are you having any new symptoms? Has anything changed? It's also very, very important for us to ask their families. So patients who have cognitive changes may not have the best insight to their cognitive changes. So it's very important to rely on the families who are spending every day with them to really get a good picture of what's going on. So Chris and Melissa are two wonderful members of our neuropsych team and have done some really amazing work in the cognitive rehabilitation space, which is not this one size fits all. This person has problems with executive functioning. They're going to go through this treatment plan and it's going to improve. But really a tailored treatment plan to each person and what their goals are. Some people, their goal is to get back to work. Some people, their goal is just to be able to do things around the house by themselves again. Some people, it's to be able to interact with their family with feeling less irritated or agitated or being able to control their emotions a little bit better. It's really tailoring that plan to each person. And one thing that they do that's been really impactful for a lot of our patients is a transition back to work. So like a simulation of, if this patient really wants to get back to work, what do they do? What does their work environment look like? Can we stimulate the amount of kind of anxiety or pressure or situation that they would be in at work, and see how they do in that space before they eventually get transitioned back. From a medication standpoint, memantine was studied really for patients who were receiving whole brain radiation to help mitigate some of these side effects, and it was given over the course of 24 weeks. But we haven't seen that it has helped with people who are receiving more targeted radiation therapy. And then methylphenidate and the ketogenic diet at the time of treatment have also shown no therapeutic benefit to cognition. So as patients ask us, well, should I change my diet? Is there anything that I can do to help my cognitive symptoms? The answer is scientifically no, there's not something that we can promote. So another late toxicity occurring in the months and even years, particularly in patients with pituitary tumors, but also patients who have gliomas or other tumors where the radiation may impact the hypothalamus or pituitary. That's why the range of risk is so large, because it really depends on the dose of radiation and how close we get to those structures. And the timeline is very, very variable. But often we can see serum changes in these people before that they have symptoms. So it's very important for us as clinicians to, one, know, is this a risk for our patient or not? And two, if we don't know this patient's radiation treatment plan, we don't have it here at UCSF, it can be very helpful for us to get that plan. What did that treatment look like? How close to those structures did they get? And this is something that I wanted to touch on in particular because, you know, many of the functions of low thyroid, hypothyroid, of adrenal insufficiency, these can have very generic symptoms, like I'm just a little sensitive to the cold, I'm fatigued, I'm losing weight. And so it's meant as a reminder that we can't just brush off those things as, well, you're going through chemotherapy treatment, but we really need to think about, could their treatment have affected them in a different way? So this is our debate, right? Pseudonecrosis versus, or pseudoprogression versus radiation necrosis. So this is often a debate that we have in tumor board. And is something that when we see on MRI is often buys that patient a conversation at tumor board. So incidence after a single fraction of stereotactic radiosurgery can be about 10%. And then after intensity modulated radiation therapy can be as high as 40%. Again, depending on where did they get their radiation, how much of the brain was treated, and how well did the dosimetrist do at kind of controlling the dose to just the treatment area. 85% of cases are in the 6 to 24 months, following the completion of radiation. So while we like to say, okay, this MRI looks great, 3 months, 6 months after radiation, we have to keep in mind that this can show up even in the years following radiation. Symptoms can be dependent on location, just like any of the things that we've talked about. And some patients may be asymptomatic. And a lot of times what we're seeing on MRI is that they have some new enhancement, particularly around the ventricles, as just kind of a signal for ourselves. But radiologic findings, you can see some T1 post-contrast enhancement. We can see that T2 hyperintensity, which we saw with the pseudoprogression. So looking at the MRIs, or remembering back the MRI from the previous slide. But really, those are the same things that we can see in recurrent tumor. So how do we differentiate what this is? And there's several imaging modalities that can help distinguish. The perfusion part of the MRI scans that we do here can demonstrate microvascular density, which would demonstrate tumor over radiation necrosis. And then Dr. Villanueva is running a study of the use of FET-PET, which is a PET scan, but unlike our typical glucose PET, because the brain has such an avid uptake of glucose anyway, it can be hard to distinguish kind of what is tumor versus normal brain tissue. And so this FET-PET is actually an amino acid PET, where the tumor has an uptake of that amino acid. And you can see it, the picture there that really shows that it glows quite hot on that exam. And then we have the same kind of management for this as we do for pseudoprogression. So a lot of times our discussion is, if we don't do one of these kind of other imaging modalities to figure it out, do we just do a short interval scan? Do we follow up in just 4 months and see, has it changed? 4 weeks, and do we see has it changed over the course of a month, or is it the same? In patients who are symptomatic, we can start dexamethasone, and in those patients who maybe can't come off a taper of dexamethasone or who are highly symptomatic, we can consider the dose of Avastin as well. So now I want to transition to some of the disparities affecting our rural and low-income patients. And like Cherrie said in my intro, this is something that's very kind of near and dear to my heart. I grew up in a very rural community, so know that access to care can often mean good outcomes versus bad outcomes. So we really have to think about the radiation oncology patient and what can affect their treatment course. So our patients who are in rural communities, if they're going to see their primary care provider and they're just having headaches, or they're having some new neurological symptoms, I'm having cognitive changes I don't think as clearly as I did, is their entry to care delayed? Do they get the MRI to look at and to get a picture of their brain, or do we kind of symptom hop and try to diagnose what else it could be before doing some imaging? Limited local resources. So is their imaging as high quality? Can they catch things earlier? Are the people who are reading the exams looking at them in the same way that maybe our radiologists would here? Unfortunately, no matter where patients receive care, having provider prejudices and unconscious bias, is this someone that's been kind of a victim of those things? Have they been ignored? Have they not felt fully listened to and with who they've seen? What kind of support network do our patients have? This is like at the start of radiation. Do they have someone who can come and bring them to their radiation every day? Do they have someone who can take time off of work and come to their treatments with them? What is their employment status? Can we get them disability? Can we make it so that they can have a livable income while they also go through treatment? What is their health literacy? Do they understand what their diagnosis is? Did they get their diagnosis somewhere else? And do they even know what it means for their prognosis? Not only from being explained to, but how well do they understand what their treatment course is? The ability to afford expenses related to their treatment. Can they come and stay in the city? Is there anything preventing them from making this? Can they afford gas to get here? Exclusion in clinical trials is a huge one. So are we having patients that are treated in the community that are not being broached with, here's this clinical trial opportunity to represent someone from a rural community, which are really typically excluded from big clinical trial opportunities. And this last one is on our bad and on other providers' bad. Are they receiving treatment locally that's maybe combined with us? Do we have good communication with their team? Do we have poor communication with their local providers? And how do we bridge that gap? How do we not make the patient the middleman to say, they told me this and they told me this, and make the burden of their care on them? So how do we as nurses overcome these? And I'll take it back to our quote. The good nurse treats the disease. The great nurse treats the patient who has the disease. We have to know our patients. We have to know who they are, who supports them, who they support, what is their support system like, not just at home. Maybe it's great at home, but can any of those people take time and bring them to their appointments? We have to do things like we're doing tonight, networking with each other, knowing our resource, not just within our community here, but also networking externally, right? Reaching out to the other centers where our patients have care, and really using our great foundation of knowledge that we have as a team to educate other nurses, to educate other providers about our patient population, which may go a little bit ignored or seen a little bit differently if they're just in a regular medical oncology practice. Forming relationships with our patient at all touch points, right? It's not just us as nursing staff. It's not just the providers. It's our patient care coordinator. It's every person that comes into contact with that patient, finding out a piece of information, but also sharing it with the team, using our patient advocacy. Hey, I found this out about so-and-so, and I don't really know whether they'll be able to make it to treatment. You know, we can do all the dosimetry and planning that we want to, but it doesn't do us any good if we don't know that the patient can actually be there. And more importantly, how do we get them there, right? How do we use our lovely interdisciplinary team to make sure that our patients are truly getting the care that we need? And not just our patients, but like we talked about with some of the toxicities, a huge caregiver burden. So how are we supporting our patients? How are we supporting their families? And how do we really get them to a place where we can get them through treatment and onto that follow-up surveillance road for as long as we can keep them there? Thank you.
Thank you so much, Krista. That was excellent. And so I'd like to open the floor for questions. So I'd actually like to invite you back up. So I'd like to invite Dr. Braunstein and Krista to join me here, and then we'll open it up for questions for anyone.
Dr. Braunstein, for patients with DIPG, what is the best, well, maybe not the best approach, but what is normally the first approach that's used for treatment? Is it surgery, radiation? And if it's surgery, do you normally prefer like the intra-op approach with imaging?
Sure, I can speak to that. So this broad class of these diffuse midline gliomas, often in the pontine area, these infiltrative gliomas, they're historically considered to be in that no-fly zone, where they're really centrally located. They're not really amenable to resection. And so historically, those patients often would just be diagnosed based on imaging alone, without any tissue acquisition, so no biopsy, with a few exceptions if they're particularly exophytic. That has changed significantly due to, frankly, a lot of work that's going on even here in our pediatric neuro-oncology group, because now we recognize, and I just state explicitly, those patients used to just be treated with radiation alone. And while that would help with symptoms, that particular disease carries a really grave prognosis, even worse than traditional glioblastomas. So these patients would really live less than a year. And so it bore forth a need to do more. And so a number of folks here, Dr. Prados, Dr. Mueller, have formed a consortium group to do clinical trials, really trying to leverage some of those molecular interrogations that we're doing and new targeted therapies and very creative therapies. To be able to do those types of trials, there is a need for tissue. And so for many patients now, they'll undergo a very limited, thoughtful intraop biopsy to be able to get tissue. It's not therapeutic in terms of reducing tumor burden, but it's enough to get tissue and to be able to inform perhaps which clinical trials are most appropriate. And so there's a number of clinical trials now, a big network for those patients with DMG, DIPG. Almost everyone that we see, we try to get them on a clinical trial to do better. Other questions?
Some of the questions that a lot of our patients ask is, why can't they get protons? The glioma patients, why not get protons? I think people ask that in the clinic.
Sure, I can speak to that first if you something like that. Okay.
You take that one.
I'm sure you get the question. I think everyone gets that question. So part of it is just to understand, I really just touched upon it, that in terms of the efficacy, protons are no more biologically potent or meaningful than photon-based therapy. There's some more advanced forms of therapy, carbon anion therapy, Germany, Japan, that may bear forth a better efficacy. But right now, it doesn't help any. What protons can do in some instances, and it depends upon, it gets into some of the W's about where the tumor is located, what the treatment looks like. It may be able to offer a slightly more, what I would say, conformal treatment, which is important. And I would say perhaps important more so for folks that are likely to realize some of those late side effects. Again, thinking about those patients with lower grade glioma. But it really is based upon the individual, thinking about what the target is, what we're doing, and is there going to be, again, that more regional scatter dose. So Krista brought up this notion of thinking about the endocrinopathies in patients. So I would advocate very frequently that for some of those primary brain tumors where the target's going to be close to something like the pituitary, that might be a better candidate for undergoing proton-based radiotherapy than someone who has a pretty well lateralized like cortical tumor where maybe it won't be as much of a dosimetric benefit. So the way that it works here often, both in adult and pediatric patients, is that usually, again, this concept of the interdisciplinary team, we'll see those patients in radiation oncology and we'll have that very frank and comprehensive discussion and give a recommendation. We're not shy to refer patients to proton centers. There's some challenges, again, about access and potential health disparity issues there. But we have that conversation and we help to facilitate that. I would say about half the patients I see, certainly in the pediatric brain tumor setting, I send for proton therapy and I have relationships with providers. It's a small network of us overall throughout the country. And so I'm able to facilitate that communication and that transfer. That all being said, in 4 very long years, we should have proton therapy available here to our patients.
Any other questions?
I have a question about fractionated radiation. So let's say, for example, their sessions are interrupted in the middle due to, let's say, holidays, or patient gets sick and they can't make it to the appointments. Is there a negative impact to the overall survival or recurrence or anything like that?
That's a very thoughtful question. So the answer is often not. The short answer is often not, but sometimes yes. And it gets into a lot of the biology and the modeling of this. Actually having a little bit of a break, that's what part we don't treat on weekends, for a little more recovery is a good thing biologically. If there's an extended break, that can actually compromise. I mean, the same way that chemotherapy, if you are on an extended break, that can compromise treatment. It gives the tumor whatever tumor residual population is there, a chance to grow, repopulate, and maybe even recur in a way that's like more treatment resistant. So there's no magic number, but we try not to make a break that's more than a week or so. And it's part of the reason, for what it's worth, why we really depend upon our surgical colleagues to do excellent surgeries with minimum complications and let us know. Chris was talking about that interval and that sprint that comes after. When is it appropriate for patients to start radiation? Because unfortunately, though rare, in our brain tumor center, if they do have a complication, some wound injury, and it's going to require like a revision surgery or for us to stop the radiation for a period of time, it's potential it could cause an issue with outcome. But there are some models where we could actually sort of add a few sessions of dose to compensate for that, so we can adjust for it. Sure.
Nicole, do you have a question?
Oh, Krista, what isotope is used in the FET PET?
Oh, goodness. Now I have to look at my paper. I think. Braunstein could probably answer this question faster than I could.
C11.
C11? C11. C11.
Just look at my crib notes.
I'm like, oh.
So I think, thank you so much. Thank you both. So I think we'll close it out, and I'll welcome Dr. Suzanne Chang again.
Thanks, Cherrie. So I just wanted to, again, thank you all for honoring Adam here. Really want to thank the family for being here. Congratulate Martina. Thank our wonderful speakers. I just think it was just amazing. It was so clear and so relevant and so important in how we take care of our patients. So thank you so much. But also, we really want to thank Cherrie, Candace, Amber, you gotta stand up. And I think Lara, right? They all helped us with coordinating all this. It was a beautiful evening. So thank you for spending time with us tonight. And safe travels home. Thanks.